All right, everybody. This is what I would say is the most important written document in microbiology, and it's the cheat sheet I put together called Antimicrobial Drugs to Know. So this is not a pharmacology class. I want to focus on the most important antibiotics, either historically or currently. Certainly, this list is constantly changing as new antibiotics are coming out. There aren't a lot of new or novel classes of antibiotics. Some would argue that there hasn't been one since 94. There have been a few individual drugs that have come out since 2000. But sadly, most of the low-hanging fruit has already been picked, so there's not a ton of new antibiotics coming out, and we know that they're being taken off of the market because of toxicity or concerns that they no longer work much faster than they're being put on the market. So, but this is not, I'm not going to just discuss the entire thing here. I just want to go through this list. I'll certainly be adding more to it. I always try to expand in the audios, as you know. Okay, so I have these organized by groups. Now, why did I say antimicrobial drugs to know instead of antibiotics? An antibiotic is something that's made by a living organism that inhibits or kills another organism. So we know that any of your synthetic drugs, or I guess even your semi-synthetic drugs, are not technically antibiotic. Now, of course, we'll call them that. The sulfa drugs are a clear example. They should be called antimicrobials, but we're going to call them antibiotics, and that's totally fine. All right, so the first group, the inhibitors of cell wall synthesis. So these are going to be more effective against gram-positives, extended or broad-spectrum varieties effective against some gram-negatives as well. So why are they more effective against gram-positives? Because the primary defense that a gram-positive bacteria has is its peptidoglycan cell wall. So any drug that interferes with the production of that cell wall is taking on its primary defense. Gram-negative bacteria have a small, barely useful cell wall to begin with. The lipid outer membrane of a gram-negative is way more important. That's why these are primarily effective against gram-positives, especially the natural ones. As we'll see, the semi-synthetic ones some of them do have an extended spectrum that allows them to be quite effective against some of your gram-negatives. So let's start with penicillin. So penicillin was, the first antibiotic. The sulfa drugs had already been around. Penicillin was discovered in the late 20s, and the sulfa drugs have been around since the early 30s. But penicillin was the first actual antibiotic. You'll notice here that I have penicillin G and penicillin V. There's actually you can add penicillin or add other compounds to penicillin. So there are other ones like benzathine penicillin and procaine penicillin. They can have they extend the amount of time that the concentrations of penicillin are in your blood, but the concentrations are usually pretty low, and there could be side effects. But these are the only two that I'll expect you to know. So penicillin G is the first, the father of all of these the future penicillins and semi-synthetic penicillins. So it is the natural penicillin, but it has to be injected. If the concentration, it just disappears really quickly, but it is still very powerful. The reason it has to be injected is it can't tolerate stomach acid. So penicillin G has a narrow spectrum, but it is, it's still very valuable against your staph and strep, your gram-positives. So narrow spectrum means that it's not going to be effective against gram-positives or gram-negatives. Now, some drugs are even more narrow spectrum than that. They'll only affect some organisms. In the future, let's hope that we have a lot more truly narrow spectrum. Right now, narrow spectrum just means only effective against half the bacteria. So I mentioned there are several preparations that increase the amount of time before it's excreted from the body. Those would be the procaine penicillin and benzathine penicillin are the most common ones. So, but I won't ask you to know those by name. Next, we have penicillin V. So this would be the penicillin that that most people are taking, unless you're getting injections for more serious infections. This is a natural penicillin, but this one can survive the trip through stomach acid, and that's why it can be taken orally. So penicillin G needs to be injected. Penicillin V needs to be taken orally. I try to think of tricks whenever possible. So G comes before V in the alphabet. I for an injection comes before O for oral in the alphabet. So penicillin G must be injected. Penicillin V is taken orally. All right, so I have a question here then. So, I didn't even mention the beta-lactam yet, but penicillin, there's actually like 50 different types of penicillins, and what they have in common is they have a beta-lactam ring. So I don't care if you understand the structure so much, but penicillins have a beta-lactam ring in the center. So all these different preparations, all these semi-synthetic penicillins, et cetera, they come from starting with that ring, which they actually call the nucleus, and then adding different functional groups or different compounds on it. That's what changes how it works and whether it can survive the stomach, et cetera. So they all have this beta-lactam ring. Now, so the question here is, bacterial response to natural penicillins is a plasmid-borne gene for beta-lactamase. So penicillinase and beta-lactamase, they're two names for the same thing. And the fact that this gene is carried on a plasmid means that evolution can happen in an organism's lifetime because of conjugation. So that process we covered before of one of the examples of horizontal gene transfer. So that's a big problem because bacteria have been within 3 or 4 years of penicillin being used commercially. There were some signs of resistance. It used to only take about 4,000 units of penicillin to be effective against staph and strep infections. Now it takes 24 or more million units of penicillin to be somewhat effective. So we know this is a problem. So antibiotic resistance to penicillin or bacterial resistance to penicillin is very common. So the question I put here though is, is it easier for bacteria to adapt to natural antibiotics? Why? So whenever you're looking at a natural antibiotic versus synthetic antibiotic, and just so you know, there are times where there is a natural antibiotic and they find it's cheaper and more effective to make it synthetically. So even the synthetic antibiotics have actually, come indirectly from natural sources. But most antibiotics are either natural or synthetic versions of something natural. So is it easier for bacteria to adapt to natural antibiotics and why? And then the answer is yes. And the why is they've been around longer. Penicillin's been around as long as the penicillium mold has been using it to fight bacteria. So when we concentrated penicillin and started to put it into pills and injections, it was more than they've ever seen. But bacteria have seen penicillin as long as they've been around. So a brand new novel synthetic drug, resistance should be slowed to it because there hasn't been any evolution yet. All right. So there were already penicillinase producing organisms. There were already penicillin resistant bacteria before we started using penicillin because they've been at war with the molds and everything else. All right, methicillin. So methicillin is an example of a semi-synthetic penicillin. It was the first penicillinase resistant antibiotic. So we coated the world in penicillin, which forced evolution forward, and then you had the penicillinase producing organisms, or the penicillin, basically the beta-lactam resistant organisms, because these bacteria, like the first resistant organisms, they had an enzyme called penicillinase that chopped up penicillin before it could do its job. And we then coated the world in methicillin. So it was the first penicillinase resistant antibiotic. But that's what led to MRSA, methicillin resistant Staphylococcus aureus. And now it doesn't even work. It's been discontinued. So methicillin was our first kind of savior for when this war of antibiotic resistance. You're going to see that we throw something at them, they develop a way around it, and the cycle continues. But so we're fighting this evolutionary arms race that we're going to really struggle to win. All right, so that was methicillin, and then they developed, then you had MRSA and methicillin-resistant organisms. And just so you know, MRSA is not just resistant to methicillin. It's going to be resistant to a lot of your beta-lactam antibiotics, including penicillins, but also like your cephalosporins and stuff too. All right, so your MRSAs are not just resistant to one organ or one antibiotic. Okay, so methicillin, then MRSA, and then we started using things like Vancomycin, which will be on the list later because it's a different type of antibiotic. So we just keep ramping up and escalating this war. All right, now let's look at some of the other semi-synthetic penicillin. So I've already told you a semi-synthetic penicillin, you stop the production of a natural penicillin when all there is this nucleus, this beta-lactam ring, and then build on it. Or you let penicillin be produced and then you change things that are on it. You remove this carbon and add this, sulfur, things like that. So that's how you make them. So oxacillin is another penicillinase resistant semi-synthetic penicillin. That's the one that's replaced methicillin in clinical use. And of course, these are constantly going to be changed. Ampicillin and amoxicillin are basically the same thing. They're both broad spectrum / extended spectrum. So what that means is when they synthesized this semi-synthetic penicillin, which is part natural penicillin and part synthetic, they were able to extend the spectrum, which means that ampicillin and amoxicillin are way more effective against gram negatives than regular penicillin would be. So that's why these were used so commonly. I know, like when I was a kid, our doctor gave us amoxicillin for literally everything. So, and we know where that's getting us now. Then we have augmentin. So augmentin, I definitely want you to know, is the most powerful of this group of drugs. So it is a broad spectrum, extended spectrum semi-synthetic penicillin. But what they did is they actually added. So when you look at amoxicillin, they actually added something called potassium clavulanate, or it's also called clavulanic acid. So it actually is a byproduct of the streptomycetes, and as you'll learn in class, half the antibiotics in use today come from this one group, the streptomycetes. And so we have the amoxicillin, which is a broad spectrum / extended spectrum antibiotic, but then you add the potassium clavulanate, which actually is going to make it even more effective. Because what it does is it actually binds to penicillinase. So if a MRSA or something is producing penicillinases to chop up penicillin, the potassium clavulanate, which is not an antimicrobial, will bind that enzyme. So that's why it's called a penicillinase inhibitor here. So if I ask you what's like the top dog semi-synthetic penicillin, this is the one that throws the most at the microorganisms. All right. Next, Promyxin. So this is actually a carbapenem, and we'll talk about these for quite a bit because this is the CRE is such a big deal. But these are actually classified as carbapenems. They do still have that same structure, that same nucleus. So they're not actually a penicillin, but they are still beta-lactam antibiotics. That's why you see that word beta-lactamase used more than penicillinase, because when an organism evolves resistance to penicillin, they basically evolve resistance to the carbapenems and other organisms or other antibiotics as well. So, all right. So what Promyxin is, it is a carbapenem. You do have to give it as an injection. It's actually an imipenem antibiotic plus something called celastin, and the reason that's important is it keeps it from breaking down in the kidneys. So what's crazy, and these numbers will certainly change, but that it's right now it's supposed to be active against 98% of organisms isolated from hospital patients. So that's pretty crazy. But that is going to change with this CRE. So Promyxin is a great antibiotic. It's a very effective antibiotic, and the celastin actually makes it more effective by keeping it in your body longer. But the resistance that's coming from this group is terrifying. So let me read this. These types of antibiotics are leading to resistance. The family of germs, dubbed CRE for carbapenem-resistant Enterobacteriaceae, which is a large family of gram-negatives, including E. coli, Shigella, dysentery, Klebsiella pneumonia, etc. Very, very dangerous. So this is the one, if you were to just type in nightmare superbugs to Google, this is what they'd be talking about. MRSA's bad, Versa, Visa, these other ones are all bad. You've got your flesh eaters and stuff. But the CREs, the CDC is actually calling them nightmares. And what they're basically saying is if these CRE organisms get a little bit more resistant, if they can develop resistance to their last line of defense, which is colistin, an antibiotic that was, it's been around since the 50s, but it wasn't being used because of side effects. So they quit using it. We started using it in the food supply, especially on, pig farms in China. And then now we realize we need this antibiotic, but the problem is all that use in the food supply is going to speed up resistance. I look at all antibiotics like they have a counter. I don't know where the number starts, but it's every time you use it, it's ticking down to zero. So imagine how many uses or how much exposure bacteria have had to colistin, this now new old last line of defense, because of its use in the food supply. But if that happens, if these CRE organisms become colistin resistant, which there have been hundreds of cases, even in the US now, they've found it in hundreds of cases in the US. If those two meet, so you take a CRE organism and teach it to resist colistin, they're calling this a nightmare scenario. CDC is, they're already calling the CREs a nightmare. But when that happens, or if that happens, they're telling us to prepare for a world without antibiotics. So take this very seriously. So let me read this quote. According to CDC resistance expert Dr. Besser, almost half of patients that get a CRE infection in their bloodstream will die from it, even with treatment. So I know everyone knows what MRSA is, but pay attention to CRE. That's going to be a bigger deal. Next, moving on, we have the cephalosporins. So they're very similar to the penicillins. the nucleus or center of a cephalosporin looks, almost exactly like the beta-lactam ring of a penicillin. So these are really the most widely used beta-lactam antibiotic right now. But bacteria have developed beta-lactamases that destroy these as well. So it's kind of interesting. I won't ask you to know the generations, but these are grouped by generations. I kind of like that because they generally, every group is going to be more effective or broader spectrum. So what it's showing is that they're constantly improving it. Clearly they've done like penicillin. Look at the list we just went through, but it's kind of neat how they group them by generations. Okay, next we have bacitracin. That's actually a polypeptide antibiotic, which is only used topically because of safety concerns. So it's one of the 3 antibiotics you'll find in Neosporin, or your triple antibiotics. So you'll see that if you look at the triple antibiotic, one's effective against gram-positive, one against gram-negative, and one against both. So it's a real nice coverage. So it is different. It is more effective, but this is probably why it's more toxic as well, is that it actually affects the ability to make the peptidoglycan chains in the peptidoglycan cell wall. The penicillins and all the other antibiotics, they just stop these little linkages from forming. So like the strands of the raft can still form, but they can't be roped together. Bacitracin actually affects it at an earlier stage. So interesting about the name, I won't ask you to know this, but it's called bacitracin because it came from the bacillus organism that was found in the wound of someone named Tracy. So bacitracin, that's just kind of neat where it gets its name. Speaking of names, we have vancomycin. So this, we thought this was going to be this very, very important last line of defense, but we know that, that we were optimistic when we thought that. But the word, it actually comes from the word vanquish. So this was really supposed to be the antibiotic that solved all of our problems, and we know that there probably will never be an antibiotic that can do that. It is called, you don't have to know this, but it's called it is a polypeptide antibiotic, but they call it a glycopeptide antibiotic too. It used to be when they first found it somewhere in the rainforest or something. It wasn't going to be effective. It was just too toxic. But they keep making this better and better. And you look over the last couple of years, that continued to be true. So it does have a very narrow spectrum of antibiotic. It's really just effective against the gram-positives and primarily, trying to solve the problem of MRSA, methicillin-resistant Staph aureus, which again is resistant to way more than just methicillin. All right, but so we threw penicillin at the world. They threw penicillinase enzymes or penicillin resistance back at us. We threw methicillin at them. They threw MRSA back at us. We threw vancomycin at them, and they threw VRE back at us, vancomycin resistant enterococci. And there's also Visa and Versa. So there's vancomycin resistant staph and other ones as well. So vancomycin resistance is usually carried in plasmids, just like the penicillinase or beta-lactamase enzymes, which means that it's going to spread very quickly. All right, so I noted here just because VRE, vancomycin resistant enterococci, and Enterococcus faecium or faecalis, very common nosocomial or hospital or healthcare acquired problem in the United States. This can cause lots of other issues, but one area where you see this is if you have a root canal and a tooth gets infected, it is like way more likely to have this organism than in any other scenario that I can think of. So this can be a very serious problem. So we've opened a Pandora's box, and now there's new organisms to deal with. All right, these last two are going to be, so remember we're in the group of cell wall inhibitors. These last two, Isoniazid and ethambutol, these are antimycobacterial antibiotics. So what they do is they inhibit the production of mycolic acid, which is that waxy lipid that's found in the mycobacteria and the nocardia. So as you see, they're Isoniazid, antimycobacterial antibiotic, inhibits mycolic acid synthesis, and the treatment time is 6 months or more. Treating tuberculosis, it can be even more than that. So these drugs, so the good news is they're a lot more selective, so you're going to see a lot less collateral damage. Like if you're taking Isoniazid and ethambutol, it's not going to have near the effect on your microbiome as tetracycline or something, a broad spectrum would. That's good. It should only affect the organisms that have mycolic acid in their cell walls, which this would primarily be used to treat tuberculosis and then a leprosy or Hansen's disease. So that's the good news. The bad news is the treatment time takes forever because remember, if you're going to be inhibiting cell walls, you can only affect actively growing cells. As they're producing cell walls, you're making them weak, and then when the cell walls get weak enough, they'll lyse or rupture. So the mycobacteria grow super slow. I mean, there are, you can have leprosy for a decade before you know it because it's a very slow grower. And there are some strains of the mycobacterium that have to be incubated for 6 weeks before you can even do testing on them. So they're super slow growing, which means any given day you're not going to kill that many of them, which is why the treatment time is forever, 6 months, 9 months, 12 months. So um, another thing, it's very difficult when you're treating things like tuberculosis. Where part of the name comes from the fact that it forms these tubercles, and they're going to be walled off inside your body's tissues. So any drug that's going to fight tuberculosis has to be able to get into and penetrate these tissues. They have to be able to get into the macrophages as well because tuberculosis can hide there too. So isoniazid is a very effective antimycobacterial antibiotic. We'll see rifampin later in the list. But the reason there's a couple of cases where we'll see this. Ethambutol is added not because it's a powerful antibiotic; it's actually less effective. There is a synergistic effect. They do work. They do work well together. But the main reason you do it is to avoid resistance. If a bacteria has to win the lottery to develop resistance to a drug, putting two drugs together means it has to win the lottery twice. So that's why, like with HIV, you're going to see cocktails of 3 or 4 or 5 different drugs because the viruses mutate quickly. I think you're going to see more and more of this in the future. Combinations of drugs to slow resistance. That's what ethambutol does. All right, next we have the protein synthesis inhibitors. These are much more likely to be broad spectrum. You'll see they're not all broad spectrum because some could certainly damage a gram-negative bacteria, but they can't get inside the gram-negative bacteria. But so all bacteria, gram-positive or negative, have to synthesize proteins. So the reason that we can use this and there's not as much toxicity concern as you might think because we have ribosomes is their ribosomes are different. So humans, eukaryotes have the ADS ribosomes and prokaryotes have 70S ribosomes. Now the clear exception though is the fact that our mitochondria have 70S ribosomes as well, which is why you are seeing, for years they thought this wasn't the case, but these antibiotics do have an effect on your mitochondria, and hopefully it's transient, temporary, and that kind of thing. But I would say if I were to look at one antibiotic and say they've found clear evidence that it can affect your mitochondria for long periods of time, that would be doxycycline, which is used to treat Lyme disease. But it's hard to say and other things, but it's hard to say if it's just the drug or it's the drug plus the illness. I don't know. But I think that we no longer believe that the idea that these antibiotics don't affect the mitochondria. We just hope it's temporary and goes away. All right, so chloramphenicol, one of its biggest values is it's very cheap. It's also small, which is cool, so it can get into spaces other antibiotics can't. So if you have to drive an antibiotic into deeper tissues, this might be effective, but it is cheap again. But it is toxic. It affects the 50S portion of the ribosome. I won't ask you, which part of the ribosome is being affected. So it's toxic. So generally they say to only use it if there's no other alternatives. It can suppress blood cell production by affecting bone marrow. So this would be when cost is the primary concern. This would be the antibiotic they would use, which in the developing world may be true. But because of toxicity, generally you don't use it unless you have to, and if there's a better alternative, try to use it. So that's chloramphenicol. Next you'll see streptomycin, neomycin, gentamicin, and tetracycline. So streptomycin is a broad spectrum aminoglycoside. All three of them are. But streptomycin is effective against the mycobacteria. So I would say that's the coolest, most important thing to know about that. But it's when it's effective, but it's losing its ability to be effective because of resistance. Neomycin, just know that's what you're going to find in Neosporin, the triple antibiotic, as well as the Bacitracin we talked about earlier. And gentamicin, and now you don't have to know this, but you'll see it's spelled differently. That's just an homage to where they found it. Don't worry about that. They're all three related. So the reason gentamicin is effective is because it is useful against the Pseudomonas and Pseudomonas aeruginosa infections. It's a common nosocomial infection, especially in people with cystic fibrosis. There's been tons of research done on Pseudomonas because of its effect on the lungs. of patients with cystic fibrosis. So what they'll actually do, a type of gentamicin that they'll use, I don't remember its name off the top of my head, but it's an aerosol that they'll use to get right into the lungs of cystic fibrosis patients. So those are the broad spectrum aminoglycosides. Next one on the list here, we have tetracycline. Everyone's heard of this one. This is what's cool about it to me is that actually it can be used against intracellular pathogens. So it is broad spectrum. It actually affects the ability of transfer RNA to bring ribosomes to the 70S ribosomes of bacteria. So good news is it doesn't affect our ribosomes, our transfer RNA, so that's good news. So if tetracycline has a negative effect, it's generally because of its effect on the microbiome. Lots of collateral damage, very, very broad spectrum. So why and when will we use it? It is effective against intracellular pathogens. So like chlamydia, so chlamydia, the STD, but there's also chlamydia pneumonia, there's other types of chlamydia, and the rickettsias, which generally cause typhus, different types of typhus, Q fever, and Rocky Mountain spotted fever. So these intracellular pathogens that get inside your cells, tetracycline can go root them out. This is when you think of a super infection, this is generally the antibiotic you're going to be thinking of. And a super infection is when a treatment, so not a super bug. A super bug would be resistant to multiple drugs. A super infection is when you do so much collateral damage to the microbiome that a secondary infection pops up. So we generally think of Candida albicans or thrush yeast infection, but C. diff would be a good example of a super infection as well. Last one in this group is erythromycin. It's called a macrolide antibiotic, just because of the ring in the center. Don't worry about that. Erythromycin is interesting, though. It is narrow spectrum. It can't get inside gram-negatives, so it's only going to be used against gram-positives. So why will we use this one? This is one that they give to kids sometimes because they can make it taste pretty good, compared to penicillin or other things. So so that would be a time that it might be used. They are working on newer generation macrolide antibiotics. So let's hope we can add to this list in the future. All right, next one's really short. Injury to the plasma membrane. This is rare because, of course, every one of your cells is a plasma membrane. So now a lot of the drugs that would actually have an effect on the plasma membrane, they're going to be more like antifungals. They're going to be used against eukaryotes, but mainly because there are going to be side effects. But different organisms take up fats and do this process differently. So you're going to see more in this group, but right now we just have the topical Polymyxin B that's going to be found in Neosporin. But it can kill Pseudomonas. It is effective against gram-negatives. So, and I do hope this list gets longer because yes, we need fats in our plasma membranes and so do bacteria, but they don't actually bring up and use fats the same way. So this might be something where we can target a pathway that we don't use. So let's hope that's the case and we keep finding new antibiotics. All right, so I guess we have two groups left. Inhibitors of nucleic acid synthesis. So all living things need DNA, RNA, messenger RNA, etc. This is rare though because we need to make purines, pyrimidines, DNA, RNA, etc. So the drugs that inhibit nucleic acid synthesis, we have to do it in a way that won't hurt us. All right. The first one here is rifampin, which is a rifamycin mRNA inhibitor, messenger RNA inhibitor. So this is a great thing to use when you're treating tuberculosis. It can actually get to the tubercles, the tubercle bacillus that you'd find in tuberculosis infection that are inside macrophages. So the interesting thing about rifampin, so it is effective for tuberculosis and leprosy. And it can get into those hiding spots, especially it can also get into the cerebrospinal fluid. So it's able to reach places that other drugs can't. The side effect is that it causes your body secretions and body fluids to be orangish red, urine, feces, tears, you name it. All right, that's rifampin. Nalidixic acid is really barely used. It was developed in the 60s as a quinolone antibiotic. It is still occasionally used for UTIs, but it's really the reason it's important is because it led to the quinolone, the fluoroquinolones. So you've got like Cipro. So everyone's heard of Cipro, ciprofloxacin. So these came along a couple decades later, but let me just read this and I'll add to it. Fluoroquinolone antibiotics have a broader spectrum than the quinolones, like nalidixic acid, more effective against gram-positives, but resistance can develop quickly. So there, but it still does have uses. It's used. Cipro is used to treat anthrax, some types of pneumonia, etc. But resistance is rapid. This is one of the few antibiotics where they say that resistance can actually even develop in the middle of treatment. We think of resistance happening over time, but people can actually start out with organisms that are sensitive to Cipro, and they can lose that sensitivity in the middle of a treatment. But so that certainly can be a problem. Okay, last one here is the metabolic inhibitors. When you look at the anti-metabolites or the metabolic inhibitors, you're usually going to see chemo drugs, right? But there are chemo drugs, immunosuppressive drugs do this. But here's an example of where we can use this with bacteria. This goes back to something we learned chapters ago about the fact that when we're looking at key differences, right? Bacteria have peptidoglycan cell walls. We don't have cell walls at all. Bacteria have 70 S ribosomes. We have 80 S ribosomes, except for inside our mitochondria. And the third big difference that we would have talked about was the fact that we get folate or folic acid from our diet. Microbes have to make it. So metabolic inhibitors, the one that we're looking at here, it actually stops the production of folic acid, which is needed to make DNA and RNA and some amino acids. So it just shuts off these organisms' metabolism. So it is called trimethoprim sulfamethoxazole. So this is the reason you put the two drugs together is they have a synergistic effect. They say it generally takes about 10% as much of these two drugs together as if you're using one on its own. The other benefit of adding drugs, like we've said, is it slows resistance. Make these organisms win the lottery twice to defeat this drug. So it is a broad spectrum synthetic sulfanilamide. This is the sulfa drugs that actually showed up in the 30s, 1932. They are bacteriostatic. So you're actually stopping these cells from making new DNA and RNA and protein, but you're not killing them. So bacteriostatic means just it stops their growth. It doesn't actually kill them in most cases. All right. Next point, both trimethoprim and sulfamethoxazole inhibit the conversion of PABA, which is para-aminobenzoic acid, into folic acid, which blocks the production of DNA and RNA. We talked about how the two drugs act synergistically. So when I see the word synergy, I think 1 + 1 = 3. In this case, 1 + 1 = 10, I guess, because you only need 10% as much of these drugs together. And lastly, there is silver sulfadiazine, which is used for burn victims. So that would be another use of a sulfa drug. So those are your metabolic inhibitors. And that is the list of antimicrobials I expect you to know. And if I expect you to know something about it, it is on this list, and I just said it to you. So hope this helps.